I think we're ready to switch to our next talk this morning. Keep us moving along. So thank you guys. We are now, bye-bye everybody.
Bye-bye, thank you.
Yes, we're going to move on to, probably one of the big things that come up every single time, you get the diagnosis of cancer and you wonder what that means and what does that mean for my prognosis and for my medical care. But the other big thing that's always in the back of your mind is cost. What's this going to cost? What's insurance going to cover? It's not just medical bills, but other bills as well. And so today we have Monica Bryant from the Triage Cancer Group that really deals with this and specializes in some of these financial concerns surrounding cancer. So I'm going to turn it over to Monica and hopefully she'll give us some great insights.
Thank you so much, Sally. I am delighted to be here with all of you today to talk a little bit about navigating insurance and how that plays into the financial piece of all of it. So a little bit of background so that you know who's speaking to you today. I am a cancer rights attorney and co-founder and chief operating officer for a nonprofit called Triage Cancer. And we provide education on all of the practical and legal issues that arise after a diagnosis, both for individuals who are diagnosed and for their caregivers and their healthcare professionals. And we do that in a variety of ways that I just want to touch on briefly, because I know even though we're going to spend an hour together today, I often find that there are going to be more questions than we might be able to address today. And sometimes after you sit with this information for a little bit, you may find that in a week or so, you have more questions. And I want you to know of additional resources. Of course, the Kidney Cancer Association has great resources, but certainly you can utilize what Triage Cancer has as well. So we provide education in a number of ways, including in participating in events, both from our partners like today and ones that we host ourselves. We host events both virtually and in person. Of course, right now we're mostly virtually, but then we also have tons of educational materials and online resources that I'm going to point to throughout today. And then you'll also have access to a resource document with clickable links so that you can get straight to the information that you need. We have animated videos, we have longer webinars, and so please check out our website for more information. But here's the thing. We know, even with all the resources that we create and all the events that we have, sometimes there are still questions that need to be answered directly. And in those situations, we invite you to reach out to us through our legal and financial navigation program. We cannot provide legal advice or legal representation, but often what we find is people just need the information about the law and then what steps they need to take next. And then they can be their own best advocate. And so if you do have those questions where you're looking to get sort of that one-on-one help, feel free to fill out an intake form on our website at triagecancer.org/gethelp. And then you'll be able to schedule a 30-minute phone call with one of our staff members. So with that background sort of out of the way, let's get into it. Financial toxicity is a term that was coined really by researchers out of Duke University in 2013. And in their research, they focused on how the financial impact or burden can be as significant to individuals who are diagnosed and their family as the physical burden that cancer treatment can often cause. But what was particularly important about this research is they didn't just focus on that financial burden, how it impacts somebody in an acute way during active treatment, but they also looked at the long-term impact. And we know that individuals have a significant financial burden long after active treatment. And our speaker in the previous session even alluded to that. You know, when you have medical bills to $500,000, that isn't something that you can just deal with quickly. So this was coined in 2013, and here we are in 2021 still talking about the problem. The reason that it is so challenging to address financial toxicity is partially because, sure, cancer treatment is expensive, but it's also because there are multiple contributing factors to financial toxicity. And if we as an advocacy community don't address all or most of the factors, we're never going to be able to effectively address or reduce financial toxicity. So from Triage Cancer's perspective, 3 of the most impactful contributing factors are health insurance status. Now that could mean having health insurance or not, but more often what we find is it's individuals who have inadequate insurance or the wrong insurance for them, or that they don't know how to effectively navigate insurance. Certainly the employment changes that can occur after a cancer diagnosis are going to impact somebody's finances. So whether they've had to take time off or as either the individual who's diagnosed or as a caregiver, or if they can go back to work, the same type of job and the same type of pay. And then all of the things that normally happen in life that might impact our finances, like moving or relationship changes. Those things continue to happen after a cancer diagnosis and just compound the financial burden that someone is facing. And so at Triage Cancer, we really have many different resources and strategies to help address all of these different factors. Given our time today, I'm really going to focus in on the first factor because it does tend to be the most significant for people, which is health insurance. Now, if you feel like you don't have a fantastic grasp on how health insurance works, you are not alone. We knew this anecdotally for years that people just really struggled. They didn't quite understand the terms that were being used. They didn't really understand the differences. And now we have tons of studies that tell us that that's true for most of Americans. In fact, only about 4% of Americans could identify the 4 most common terms ever used in a policy. It's like learning a new language, but nobody's ever taught that language. So if you don't understand the language that's necessary to figure all of this out, how can you possibly be expected to pick the right policy for you? And what we know is about only 40% of Americans feel very confident that they know how to pick the right policy. So all of this is to say, if you are sitting here listening thinking, I kind of get it because I've been forced to figure it out through this whole cancer experience, but I wish I understood it more, you are definitely not alone. And I'm also going to just make sure that we're all on the same page by starting with the basics. There are certain terms related to costs that everybody needs to understand, regardless of where they get their health insurance. And the first is your monthly premium. This is the cost that you have to pay every single month just to have health insurance. And you're going to pay it every single month, whether you access doctors or not. It's like having car insurance all year, but never getting into an accident and filing a claim. But then there are some other costs that you're going to incur when you actually go and use your health insurance. These are going to depend on the plan that you have. So each one is going to have a different amount, but every plan is going to have a deductible. And this is a fixed dollar amount that you have to pay out of pocket each year before your health insurance company starts picking up their share of the costs. You could have a $0 deductible, you could have a $5,000 deductible. It's all going to depend on the plan, but whatever it is, you have to pay that amount first, and then the insurance company pays their share. Their share is referred to as cost share or co-insurance, because you're literally sharing the cost. And this is always going to be given to you in a percentage. So if you've got an 80-20 plan, it means once you've met your deductible, the insurance company picks up 80% of your healthcare costs and you're responsible for 20%. Now, many policies also have an additional payment called a co-payment. And this again is going to be a fixed dollar amount that's going to depend on the policy that you have. It may also depend on the service we're getting. So for example, it's very common to have a policy with a $25 copayment when you go to the doctor, or a $35 copayment when you see a specialist, or a $250 copayment when you go to the ER. So they're all going to depend on both the policy and the service. Now, one of the most important things somebody could know about their health insurance policy is what is the out-of-pocket maximum. Now, this is, in theory, the most that you're going to pay out of pocket for your healthcare per year. And the way that you get to the out-of-pocket maximum is by adding up everything you pay towards your deductible, everything you pay towards your co-insurance, and everything you pay towards your co-payments. So it's everything you're paying out of pocket except that monthly premium. Now, I said generally because the devil's in the details. Typically, policies will only count payments made towards in-network providers towards that out-of-pocket maximum. And some employer policies might have a slightly different math problem there. So for example, some employer policies might say, we're not going to count your deductible towards your out-of-pocket maximum. So for someone with an employer policy, it is really important to check to figure out how that policy is going to calculate that out-of-pocket maximum. But here's an example as to why understanding all of this is so valuable. Meet Dan. Dan has an insurance policy with a $2,000 deductible. It's an 80-20 co-insurance and an $8,000 out-of-pocket maximum. Dan hasn't used any of his medical care yet for the year, but he gets into an accident and ends up with a $102,000 hospital bill. Well, what does Dan have to pay? The first thing we always pay is that deductible. We subtract it from the total bill and it leaves $100,000 left. So now he has to pay his co-insurance of 20%. 20% of $100,000 is $20,000. But does he have to pay that full $20,000? No, he doesn't. He only has to pay another $6,000 to get to his out-of-pocket maximum because he's already paid $2,000 in his deductible, so another $6,000 gets him to that out-of-pocket maximum. Now, I am not suggesting that $8,000 isn't a lot of money. Of course it is. But when we start to think about the alternatives of what he would be responsible for if he didn't have an out-of-pocket maximum, which would have been $22,000, or what he would have to pay if he didn't have health insurance at all, which would have been $102,000, the $8,000 starts to feel a little more reasonable. And either way, it helps us as consumers plan for a worst case scenario. Now, if you would like to hear any of that again, or you think there are people in your life that might benefit from hearing that information again, everything I just said with respect to the terms and this example is included in our animated video on health insurance basics that's available in multiple languages and has closed captioning. So when we're talking about insurance, most insurance policies fall into the category of something called managed care. And managed care isn't just one thing. And in fact, there are many different types of managed care policies. These three that I'm going to talk about are the most common, but they are not the only. So the first type of managed care policy is a health maintenance organization, or an HMO. These are going to be policies that have a smaller network of providers that you have to go to. They're going to require that you always start with a primary care physician for your medical needs. If that primary care physician can't solve whatever the problem is, then they can refer you out to a specialist. Typically, there is limited, if any, out-of-network coverage in HMOs. In exchange for less choice and more hoops to jump through, you're going to pay less for HMOs. Another common type of managed care plan is a preferred provider organization, or a PPO. These are going to have larger network of providers, many times across multiple hospital systems. Most of them have some out-of-network coverage. So certainly you're not going to be as covered at as high of a rate if you go out of network, but there's some coverage. You don't have to start with a primary care physician. So if I want to go straight to a specialist, I can do that without a referral. So in exchange for more choice and more flexibility, I'm going to pay more. And then there's sort of a hybrid of the two in exclusive provider organizations, or EPOs. And these are going to have a larger network of providers compared to an HMO, but there's going to be no out-of-network coverage. And so in exchange for a little bit more choice with EPOs, you're going to pay more than with an HMO, but less than with a PPO. And the reason I walk through all of this is because oftentimes people are presented with choices between HMOs and PPOs, and they can't really understand why one might be beneficial to them over the other. It's also when I'm in person and the hands shoot up and they say, well, which is better? And the answer is always, it depends. It depends on what's available to you in your area, and it depends on your needs. For somebody who doesn't really have any serious medical conditions and rarely goes to the doctor except for an annual checkup, maybe a HMO is the better option for them. Conversely, someone with a cancer diagnosis who maybe is at the doctor, it feels like every 30 seconds and has doctors across multiple hospital systems, probably a PPO is going to be the better choice there. So this is our first example of health insurance is never going to be one size fits all. So with some basics under our belt now, I want to move on to our health insurance options. There are 3 places in this country where we get health insurance. The largest number of Americans get their health insurance through an employer. The next largest group gets their insurance through the government, primarily through Medicare or Medicaid. And the smallest number of Americans goes directly to a health insurance company for their coverage. So I said that the largest number of Americans get their insurance through an employer. And I've also said that cancer diagnoses often lead to employment changes. So it begs the question, what happens to somebody if they are leaving their job? What do they do for health insurance? COBRA is the federal law that allows eligible individuals to keep the exact same health insurance policy that they had when they were employed. You do have to work for an employer with 20 or more employees to access COBRA benefits, but the benefit here is it's the exact same policy. You don't have to try to find a new policy with the same providers, the same coverage, the same prescription drug coverage, and everything keeps going. So everything you've paid towards your deductible or your out-of-pocket maximum for the year continues. The downside of COBRA is that it can be expensive because now you're going to be responsible for 100% of the monthly premium, plus sometimes a 2% administrative fee. So that monthly premium can feel very expensive. But for some people, particularly if they've already hit their out-of-pocket maximum for the year, it may actually be the more affordable option. Now, for people who work for smaller employers, they may have similar rights under a state COBRA law. And so the details definitely vary state to state, but this is just sort of an example of the states that have COBRA laws and how long COBRA coverage would last in those states. For more in-depth information about what's available in your state, you can check out our charts of state laws on the Triage Cancer website, and they click over to more information about the states. Moving on to the next largest group of Americans who receive government health insurance. One of the 2 primary programs is Medicare, which is a health insurance program funded by the federal government for individuals who are over the age of 65 or who have been receiving Social Security disability insurance for 2 or more years, or who have end-stage renal disease or ALS. Those are the only ways to be eligible for Medicare in this country. Now, one of the challenges with Medicare, is we talk about it as if it is one thing, but in reality, it's 4 different parts, and those parts are identified by letters. This is going to be the 50,000-foot view of Medicare, but I do just want to point out we have many, many resources on Medicare for those of you who are interested. So when somebody's trying to figure out their Medicare options, there's 2 lanes they could potentially drive in, and they do have to pick one lane at a time. The first is Original Medicare, where they get Part A for their hospital insurance, inpatient type care. They get Part B for their medical insurance, which is going to cover things like doctor's visits and immunizations and IV chemotherapy. Then they're going to decide if they want prescription drug coverage. And if so, they're going to pick up a Part D plan from a private insurance company. Now, Part A and B have out-of-pocket costs, and Part B has a 20% co-insurance and no out-of-pocket maximum. So that can be very scary for people, particularly those that have a serious medical diagnosis, because that 20%, when you think about how expensive cancer treatment can be, 20% of a lot is a lot. So there is an additional type of insurance policy that somebody can purchase called a Medigap plan, also known as a supplemental plan. And these can help cover the costs that you would have to pay out of pocket. So that's lane one. And there was a recognition that potentially having 3 different premiums and 3 different deductibles, it's a lot to keep track of. So an alternative was created in Part C, otherwise known as Medicare Advantage. Part C plans are sold by private insurance companies, and they bundle all of the services that you would get under Parts A and Parts B. Many of them include prescription drug coverage as well, but if you pick one that doesn't, you could always pick up a standalone Part D. One of the benefits of driving in lane 2 is that Advantage plans do have an out-of-pocket maximum. A disadvantage is that lane 2 comes with a small network of providers, whereas lane 1, you can go to any provider around the country that accepts Medicare. So I, again, fully recognize that that's the fastest description of Medicare ever, and it probably left some of you with more questions than you had when you started. But earlier this week, I did a 90-minute webinar all on Medicare that's archived on our website that you can take a look at. And we also have new resources just launched this month, 4 different animated videos on the different components of Medicare. I'm also happy to answer questions. So that's Medicare. The second federal program is Medicaid. Now, prior to January 1st of 2014, the only ways to be eligible for Medicaid were to have a low income, a low resource level. So that's things like a savings account, a retirement account, a life insurance policy, and be able to walk through one of these 4 doors. Now, most of the time in the cancer community, people were walking through this door on the left through the Age, Blind, and Disabled program. I recognize it as a terrible name for a program. I did not name it. But the challenge here was that it's an incredibly high standard of disability. And for people who were working prior to a cancer diagnosis and maybe had savings or had a retirement account, they literally had to spend it all, leaving them with nothing in order to access the Medicaid program. Excuse me. So in walks the Patient Protection and Affordable Care Act, otherwise known as the ACA or Obamacare. And the ACA created a 5th door of eligibility. And this 5th door is just based on income. So for people with incomes at or below 138% of the federal poverty level, they would have access to Medicaid. Now, the original 4 doors still exist. We've just added a new one. This was supposed to happen across the country. We were going to reduce disparities, increase access to care. The Supreme Court got their hands on the Affordable Care Act and muddied the waters and essentially made it voluntary for states to expand. So here is where we stand today. The 39 states on the left have expanded Medicaid. The 12 on the right have not. The 12 on the right represent about 3 to 5 million people who would have access to healthcare had their states expanded. Now, I will tell you that this is the slide that changes most frequently. And so for updates, feel free to check back on our website. Now, the ACA also did something to make it easier for individuals who didn't have coverage at the bottom or the middle of our triangle to access health insurance. And they did that by creating the state health insurance marketplaces. So these marketplaces were originally called exchanges when the law was passed, but it turns out no one knows what that means. So they renamed them marketplaces. No one knows what that means either. The easiest way to talk about these is to think of them as a health insurance shopping mall or Amazon for health insurance. What is being sold in these marketplaces are insurance policies sold by private insurance companies. Blue Cross Blue Shield, Humana, Aetna. It's just being sold through the framework of the marketplace. So if they're being sold by private insurance companies, why wouldn't you just go straight to an insurance company? Why bother with the marketplace? The reason is that there are some advantages to buying in the marketplace. So there is some quality control. You know that what you're buying in the marketplace is a comprehensive plan. There's also a cap on the out-of-pocket maximum. In addition, there is financial assistance to purchase plans. Now, the financial assistance is based on household size and income level, so it really is going to vary. But we hear all the time that people come to us without insurance and we say, well, why didn't you check in the marketplace? And we now have statistics that shows us 67% of them didn't even look. And most of the time it was because they didn't think they could afford a plan. When in reality, if they had actually looked into it and started an application, they could have seen that they could have gotten help to buy that plan. And in fact, we know something like, don't quote me on the statistic, something like a quarter of the people who are uninsured right now could have a free plan through the marketplace. So when we talk about financial toxicity and we talk about access to care, understanding the options is step one. Now, there are certain times of year when you're able to pick up a plan. The timing is going to depend on the type of coverage we're talking about. Medicaid applications are accepted year-round, so as soon as somebody becomes eligible, they can apply and their coverage will begin shortly thereafter. Medicare, there's actually 4 different enrollment periods, and it is going to depend on your birthday and your circumstances. But for everybody enrolled in Medicare, there's an annual open enrollment between October 15th and December 7th. Employer plans are going to vary, but typically employers will do sometime in the fall. And then marketplace plans, annual open enrollment is between November 1st and January 15th. And I apologize, it should say January 15th, 2022. So marketplace plans and Medicare plans are calendar year plans. So even if somebody picks a plan on day 1 of open enrollment, that plan won't start until January 1st. But the ACA and Medicare recognize that things don't just change for somebody during open enrollment. So they both have special enrollment periods. And this is when somebody has a life-changing event that results in loss of coverage or some other change that impacts their coverage, they can enroll in new coverage. And so for the marketplace, you have 60 days, Medicare is slightly different. So all of this is to say that for somebody who now is potentially going to experience a loss of employer-sponsored coverage, for example, they've been working, they're diagnosed, they can no longer work, they actually have more options for insurance than they've ever had in the past. So their first option could be COBRA or state COBRA to keep that exact same insurance policy. Second option could be maybe buying a totally new policy in the marketplace through a special enrollment period and potentially getting financial assistance to purchase that plan. The third option could be potentially they're eligible for another group plan. So could they go on a spouse's plan at work? Or if they're under the age of 26, could they join a parent's plan? And then finally, maybe now because of circumstances, they are eligible for Medicare or Medicaid. But the trick with this is to understand your options and the pros and cons of each option, pick a lane, and then stay in it. You don't get to change lanes until the next open enrollment period. And here's why this matters. Many times we hear from folks that they were leaving their job, they were stressed, they were overwhelmed, so they just accepted COBRA because it was the easiest thing to do. They're a few months in now and they're thinking, I can't possibly maintain these COBRA premiums. Can I go to the marketplace now? And the answer is no, until open enrollment. And then you still have to keep your COBRA through the end of the year until the marketplace plan starts in January. So we just want people to be aware of all their options before they make those decisions. I recognize I'm saying a lot and I'm providing a lot of information. but I'm also just going to reinforce that there are plenty of places on our website where you can hear this all again and get more information. And then of course, call us and ask questions. And particularly for losing employer-sponsored insurance, we have that animated video and what we refer to as quick guides, which are short downloadable documents that you can read through. So we have all these options now as consumers, which is fantastic. How do we actually make the choices between the options? How do we figure out which lane we're supposed to be driving in? And then once we figure out which lane, how do we make choices between various plans we might be offered? I'm going to give you an example using marketplace plans, but this same analysis works whether you're trying to compare two marketplace plans, whether you're trying to compare between different plans your employer might offer, whether you're trying to decide, do I take an employer plan or maybe do I pick up a marketplace plan? Or even if you're trying to decide between Medicare Advantage plans, same exact analysis works. So here we have 3 different plans, and I'm trying to figure out which plan is going to cost me the least at the end of the year, assuming I'm going to hit my out-of-pocket maximum. With cancer treatment, that's often a fair assumption. So first, I have a bronze plan with a $173 monthly premium, a $6,000 deductible, and a $6,000 out-of-pocket maximum. A silver plan with a $271 monthly premium, a $2,500 deductible, and a $5,200 out-of-pocket maximum. And then a platinum plan with a $400 a month premium, a $0 deductible, and an $1,150 out-of-pocket maximum. Can we tell just by looking at this which plan is going to cost us the least at the end of the year? I cannot. I actually have to do the math. And the way that you do the math is you take the monthly premium, multiply it by 12, because that's how much you're going to pay for the whole year in premiums, and then you add the out-of-pocket maximum. So when we do that for all 3 plans, we see that that platinum plan with the almost $400 a month premium ends up being over $2,000 less expensive at the end of the year. Now, I will 100% admit to you, we do this all over the country. Every time we pull numbers from the marketplace, it ends up different. So it might be that that bronze plan ends up being the cheapest. But the point is, this is step 1 to figure out avoiding financial toxicity and how to plan for sort of the worst case scenario with respect to out-of-pocket costs. Even if that platinum plan ended up being more expensive by the end of the year, there is still a couple of different reasons why someone might choose it. Because we're not just going to look at the final total amount of costs. We also need to make sure we're looking at things like the deductible. So that platinum plan had a $0 deductible, which means the insurance company starts picking up 90% of that person's healthcare costs on day 1. Whereas the bronze plan had a $6,000 deductible, which means someone has to pay $6,000 out of pocket right away before the plan picks up anything. For most of us, it is easier to pay a little bit more each month throughout the year than it is to come up with a $6,000 check. So sometimes we have to look past that full total annual amount and look at the other components that are going to make it possible for us to have a particular plan. And then before we sign on any dotted lines, we have to make sure that any providers, doctors, hospitals, imaging facilities, pharmacies that we need to utilize are included in that plan's network. Because remember how I said, most of the time, out-of-pocket maximums are only going to count payments made towards in-network providers. This is where that becomes really important. If you pick a policy and you're seeing out-of-network providers, the math we just did is going to be irrelevant because you're going to have to pay out of pocket for those out-of-network providers on top of it. Similarly with prescription drugs. So it's very, very important to the extent possible to make sure that any prescription drugs you're taking right now, or that you can possibly anticipate taking in the year ahead, are going to be covered under that plan's drug formulary. Again, I know this is new for many of you, so we do have an animated video that goes through all of that again, called Picking a Health Insurance Plan. But here's the bad news. Picking the right plan is only half the battle. Once we have the plan, we also have to make sure that we are effectively using that plan. And definitely that means going to in-network providers whenever possible, but it also means appealing any denials of care. And the unfortunate reality is that many, many, many millions of claims get denied by insurance companies every day. The good news is, as consumers, we have some rights where we don't necessarily have to take no for an answer, but we do have to take proactive steps to appeal those denials. Generally speaking, there are two levels of appeals. There's an internal appeal where you're going back to the insurance company and saying, reconsider this denial. And then there's an external appeal where you get to go to an independent entity to have them look at the situation and the policy and decide whether or not the insurance company should have covered it. While I recognize this is an added burden on people who are already dealing with too much, it is almost always worth somebody's benefit, worth their time to go through the appeals process, because we know that somewhere between 40 and 60% of all appeals are decided in favor of the patient. It can be a lot, and so we have some tools to help people stay organized through the appeals process, including an appeals tracking form that can be downloaded on our website. The Post-it note method of keeping track of conversations and to-dos is not a good idea here. We also know that while people are, for the majority of the time, successful in their appeals, it is a vastly underutilized process. And just in the marketplace, we know that less than 0.2% of all denials are ever appealed. Less than 0.5% ever get denied. And when we're talking about financial toxicity, and when we're talking about maintaining financial health, this appeals process is an incredibly important component. We also know that even if you've picked the best insurance policy you possibly can, there's still going to be medical bills. And so how do you deal with those medical bills, particularly if you're in a different financial situation than you were prior to your diagnosis? There are some strategies that you can utilize even before you get care. And the number one strategy is to communicate with your healthcare team about costs. Now, I get a lot of pushback about this from providers and from patients about they don't really know what it's going to cost until it gets billed. But here's the thing. Healthcare is probably the only thing that we purchase in this country in this way. Imagine going into Best Buy and telling somebody, I need a washer and dryer. Don't tell me how much it's going to cost. I don't get very much choice in which washer and dryer. Deliver it to my home, and then 3 to 6 weeks later, send me the bill, and then I'm legally responsible for that bill no matter what. That's how we consume healthcare in this country. So we need to change the culture of that and make it okay to talk about finances on the front end. And maybe we won't have absolute hard numbers, but there needs to be a conversation, and I'm talking to the healthcare providers out there today too, with patients about their concerns around finances, because that can be part of the treatment process. For certain types of care, there may be less expensive alternatives. So is it possible, if you're at a hospital system and the lab that they normally use isn't in network, having the conversation with the providers and finding an in-network lab can sometimes save thousands of dollars. Similarly, sometimes with testing, there can be standalone facilities that are less expensive. Occasionally, it's about grouping follow-up appointments, so there's fewer co-pays to pay. And then sometimes there might be a equally effective but less expensive treatment option. And that might not be for the primary course of treatment for your cancer, but if you are having to take other types of medication or treatments, maybe to manage side effects, there could be other generic medications that you could take. Now, I am not suggesting you take a less effective form of treatment just for financial reasons, but the point is there has to be a conversation between the healthcare team and the patient to see if that's a possibility. Now, once you receive care, you're going to get several pieces of communication. Previously, this was all sort of done snail mail. Many times now, facilities have like online portals or they'll send emails. Sometimes they're going to send a note just to say, we've gotten a claim. Then we're processing your claim. And then finally, you're going to get your explanation of benefits or your EOB. And this is probably the most important thing for you to look out for. This is just an example of an EOB, but here are the kinds of things that you need to kind of be aware of to look for on an EOB. Every EOB is going to somewhere in big black letters say this is not a bill. Then there's going to be some information about the policyholder of the insurance policy and the patient, if it's a family policy. There's going to be some information summarizing what was billed, what was approved. There should be some specifics about what exactly is included in this EOB. Now, I have to tell you, not all EOBs are created equal, and many of them don't even have words. They just have this code called a CPT code. Now, it is unfortunately important to understand what's being billed. If there aren't words, or if you're like, I have no idea what this was for, contact your healthcare team, contact the billing department, get clarity. I cannot tell you how many times we've seen mistakes happen on these EOBs in terms of billing. Maybe it was a test that was ordered that you never actually got, or maybe you were billed, and this is a true story, for 11 surgeries instead of 1 because the biller accidentally hit the 1 twice. There should also be some information about what was covered under the insurance policy, and then finally what you are responsible for. Now, a good EOB may also have information about what you've paid towards your deductible and your out-of-pocket maximums, if applicable. And then finally, the fourth piece of mail that you could potentially get is the bill. And this is going to be from your provider. The challenge is that it often doesn't happen in this order. Providers tend to be faster at sending patients bills than insurance companies are at processing the claim. And if you just pay that bill before you see the EOB, you may end up paying more than you actually are supposed to, and then be in a position of having to try to get money back from a provider. So the rule of thumb is to wait until you receive your EOB, until you pay a bill. But this can't happen in a vacuum. If you get a bill from your provider and you see a due date coming up, contact the provider, let them know, I got the bill, I haven't gotten my EOB yet, can you push back the due date? Or can you make a note in my file? In over a decade, I have yet to hear there being a problem with this strategy. It is incredibly important to match your EOBs with the bills and make sure that you are being charged appropriately. This is a huge pain in the butt, and I fully recognize it. So this is an area where I actually think it's a great time to delegate to friends and family. For all those friends and family that say, let me know if there's anything I can do. Great, you know what you can do? You can come over, you can open up all my mail, throw away the junk, find the EOBs, find the bills, and match them together so that all I have to do is go through a nice neat stack of the bills and make sure that everything seems correct at that point and figure out what needs to get paid. It sounds simplistic, but when we're talking about a limited amount of time and energy, that could be a huge game changer. I've talked about checking bills for accuracy, and I think sometimes that's something that patients and family members can do on their own. Sometimes you've got to call in the professionals. And we have a partnership with a for-profit agency or company called CoPatient. And what they do is they help people, they take all their medical bills and all their EOBs, and they figure out if somebody's been billed incorrectly. And then they can actually help them get back some money, or if they've been billed correctly, negotiate payment plans or other types of solutions. Typically, this is a paid service, but through our partnership with them, they're offering individuals who have learned about them through Triage Cancer a year free of services, as long as you sign up by September 30th. More information on our website about that. Now, the reality is, even if you've picked the best plan, even if you're doing all the things that I've talked about in terms of navigating and utilizing your plan effectively, there may still not be enough money in the pot to do all the things. And that's where financial assistance might be useful. But the reason I talk about it last is because there simply isn't enough financial assistance to solve everybody's everything. So we want it to just be a piece of the puzzle and not the first solution that people jump to. That being said, there are some great resources out there. We've seen an uptick in crowdfunding over the last couple of years. So this is like online fundraisers. GoFundMe, for example, is an example. Give Forward is another. These can be a great way to engage friends and family. So they'll let me know if I can do anything. I need some help here. We do just want people to think about the ramifications of crowdfunding before they jump feet first. There could be some disclosure issues there in terms of now all the information is publicly available about your medical situation online. There could also be some ramifications if you are in a government program whose eligibility is based on finances, like Medicaid or supplemental security income or food stamps or Section 8 or student aid. Getting an influx of cash from a crowdfunding campaign could jeopardize those benefits. There are some solutions, and we've outlined those in our quick guide to crowdfunding. Now, in other sources of financial assistance could be local, state, county organizations. There are many wonderful cancer organizations and private programs that can help on different issues. And on cancerfinances.org, which is a website that we host, we have a financial assistance module. It's broken down by category so that you can pick a category and look through potential options. Unfortunately, there isn't a comprehensive sort of global application for these programs. You do have to go program by program and look at the eligibility requirements and look at their applications and complete those applications one by one. So it can be daunting and very time consuming. So on Cancer Finances, we've tried to sort of narrow things down to vetted, reputable organizations that have programs for individuals specifically in the cancer community. We also know that there are programs to help people manage prescription drug costs. And those could be through a pharmaceutical company or through a specialty pharmacy. And these programs are incredibly beneficial and often overlooked. We often hear from our pharma partners that people aren't utilizing or tapping into their assistance programs. So we definitely recommend those. And these programs aren't always just pure financial assistance like drug vouchers or copay assistance. They also have some programs where they give you information that can be helpful if you need to file an appeal because taking that drug was denied. So I strongly urge you to check out relevant pharmaceutical company programs to you. And then finally, in this last year, there have been a whole host of financial assistance programs that have come out related to the COVID-19 pandemic. So things like mortgage relief and renters relief and utility assistance and food assistance. And you don't necessarily, for many of these programs, have to have been negatively impacted by the pandemic to benefit. So I do suggest that you take a look at those as well as the other two sections that I've talked about. The key with finding financial assistance is not to get tunnel vision. Many times people will call us and say, I need help paying rent. We can't find them rent assistance, but what we can find them assistance with is paying their co-pays or their prescription drugs. So then we can get them that assistance and they can shift any money they had ready to pay those things to their rent. I often call it financial Jenga. You're taking pieces out here and putting pieces up here, and you're trying not to have the tower fall. And it does take quite a bit of creativity to do that. So these last couple of slides are just screenshots from Cancer Finances. You'd go to the homepage, which you can get to off of triagecancer.org. You'd pick financial assistance, and then you pick from the drop downs. Then you'd get a list that looks something like this with the website, a quick description, and phone numbers for contact information. And before I turn it back over to Sally for any questions that there might be, I just want to let you all know that you are invited to the Triage Cancer Conference that is happening next month. It is a day-long event over Zoom. It is totally free to attend, and we spend the day doing a deeper dive into many of the topics that have come up today. We are closing registration for this program on Monday, but if you have time and you're interested to register between now and Monday, we would love to have you. So with that, I'm happy to take any questions, Sally.
Thank you so much. I think, considering regardless of, who's listening, patients, caregivers, open enrollment is coming up. So this is a sort of great, one-step sort of way to go through a lot of these topics. And for all those people asking, yes, this is something we do have, recorded. So if you do need to sort of listen to that, Monica mentioned a bunch of great resources on the Triage Cancer website that goes through these things in written materials or recordings. We do have a couple different questions. One is, many cancer patients are on Medicare. If you're receiving infusions, Medicare plus supplemental plans can often cover all but a small amount. But if you have to actually switch to like Part D, and you're on something like Cabo, these costs can skyrocket. So, how can one sort of minimize the cost with these infusions on Medicare Part D?
It brings up a major gap in Medicare coverage in that, depending on the type of treatment that you're receiving, it's going to be covered under a different part. And the person who asked the question is absolutely correct in that if it's covered under Part B, then, and you have a Medigap supplemental plan, then you really can be very well protected. Part D prescription drug coverage doesn't have an out-of-pocket maximum, and supplemental plans don't cover out-of-pocket costs within Part D. Now, things have improved slightly over the last couple of years, thanks to the Affordable Care Act, because there used to be this gap in coverage called the donut hole in Part D, and that has been closed. So at least now there's coverage throughout. But even once someone gets to that catastrophic coverage, they're still paying 5% of their prescription drug costs. And as we know, some of these drugs are in the hundreds of thousands of dollars. And so that is a huge problem. There isn't a great answer, to be perfectly honest. There are legislative proposals pending in Congress to try and help with this problem. And so for any of you who are concerned, I definitely suggest you check out our advocacy page for more information, to contact our elected officials about this. So some of the proposals are like, put an out-of-pocket maximum for certain types of drugs, like cancer drugs. For individuals who have lower incomes, there is a Medicare financial assistance program called the Low Income Subsidy, also known as Extra Help, that you can apply for through Medicare. But for individuals who have higher incomes, there really isn't a great answer.
I think it's important, we always think about people with higher incomes, they can afford the cancer care. Just because you have a higher income doesn't mean you don't have higher expenses or debt or other circumstances. So people in those categories need to realize that although it may be a little harder of a struggle, there still can be, based on need, still some programs available for them that they need to make sure to ask about. And don't be ashamed, maybe because they're a physician, to say, well, I'm a doctor or I'm a lawyer, I should be able to afford my health care. Financial toxicity happens to every category.
Thank you so much for bringing that up, honestly. So quick caveat, on our navigation program, in the span of 2 hours, I talked to somebody who was in receiving Section 8 housing, and I talked to somebody who was in the C-suite of a major international corporation, and they basically had the same question. So this is absolutely a problem that is cross-cutting.
Now, if we think about, it's hard enough for a patient who has their insurance that they're trying to understand. Sometimes they'll go to their doctor and try and get it explained. Well, the doctor's dealing with every insurance policy and doesn't understand. Even when you have Blue Cross Blue Shield, 2 different patients can have 2 very different Blue Cross Blue Shield plans. They can have different out-of-pockets based on a family or a single plan. And so is there any way, especially during something like open enrollment, where is there a resource for one-on-one assistance? And how do I sort these out and understand what might be the best plan for me?
So first of all, I just want to give sort of support to the healthcare team. You have to remember, they are experts in the medicine. If you asked me about, kidney cancer treatment, I wouldn't know what to tell you. So it's understandable why they don't know all the ins and outs of insurance. Yep. Just want to throw that out there. In terms of getting one-on-one help, it is going to depend on the type of insurance we're talking about. So if you are on Medicare, there is something called the State Health Insurance Assistance Programs, or SHIP programs, and those are available in every single state. And these are individuals who are trained to help consumers navigate their choices in the application process. A similar resource exists in the state health insurance marketplaces. They're referred to as in-person assisters. And again, they can sit down and kind of walk you through the application process for the marketplaces and help you navigate the different pieces. Outside of those 2 programs, not really. And that's really why we try at Triage Cancer to provide resources and tools in a variety of formats to help people work through all of this. And by the end of the month, we will have an additional resource on our website. It's a worksheet that you can it helps you guide, fill out all the different pieces you need to collect about various policies to then figure out and compare which one might be the best for you. So
definitely a great resource. I'd love to see the math that you had, where some people think, oh, well, if I'm paying more per month, that's going to hurt. But when you do, especially if you're healthy, when you sign up for that, if something major does happen, sometimes the monthly premium, you want it to be higher because your actual big cost when it comes to those bills will be less. I think the other big thing that I love that you pointed out was the EOB, that explanation of benefits. I don't know how many times I had patients come to me being like, I can't pay this. This is huge. Not realizing that was the explanation of benefits and how to walk through and double check that. So I think that's a great resource. And I think one of the last questions is pre-existing conditions. So for those patients who have already had a diagnosis that are now up for open enrollment, what's the issue with it? Can they get denied from picking an employer insurance or an ACA plan because of their pre-existing cancer diagnosis?
So I'm delighted we get to end on a happy note, which is thanks to the Affordable Care Act, as of January 1st of 2014, insurance companies can no longer deny selling you a policy because of a pre-existing condition. They can no longer deny covering a service related to your pre-existing condition, and they cannot charge you more because of a pre-existing condition. If you are in a situation like you're talking to an insurance broker and they're saying, oh, because of your cancer diagnosis, this is the premium, be very, very wary, because chances are what you are about to purchase isn't comprehensive health insurance. And if you are concerned about that, I definitely suggest going through the marketplace, because then whatever you are purchasing is going to be comprehensive coverage. Same with employer plans. You cannot be denied or charged more based on a pre-existing condition.
Yeah, I definitely wanted you to answer that. I'm glad, to have that out there, because I do think there's so many websites. If people are going to ones that are ancillary, it's not really that ACA affordable health care, and they may get plans that aren't that comprehensive coverage. So that's definitely very important for those out there that are thinking or need to be switching plans at this point, to make sure that if you do get that little ding from them because of a pre-existing condition, that you double check where you're going. And there might even be a place where you can report it to ACA if it is a comprehensive coverage and they're still telling you they won't cover the treatment for a pre-existing condition.
Absolutely.
So we definitely make sure we'll have some resources and links available to you, that we'll send after the meeting. But Monica, this was it was dense. And I know there's a lot of I did a lot with billing and reimbursement. So to me, it's all in here. People may need to listen to it 4 or 5 times, but this is definitely a great overview of all the different things that are out there that will touch on many of you. So thank you, Monica, for joining us. I think this has been a wonderful presentation. We are going to take a 10-minute break. There's definitely bathrooms that need done. People need to recaffeinate. You've got kids banging on the door. So go take care of that. We're going to take a 10-minute break, and we will see you at 11:15. Thank you.